All right, welcome to another deep dive this week. Before we get going, just got to remind everyone that everything we discuss here is for educational purposes only. No commercial anything.
Right.
Just trying to summarize some cool research for you. And as always, you really should go and check out the full publication if you want the whole picture. Speaking of publications, this deep dive is based on a 2025 neurology paper.
Yeah, a really interesting one comparing the MoCA and the MMSE.
Yeah.
You know, the Montreal cognitive assessment and the mini mental state exam.
The classic cognitive test.
Yeah, but this time looking specifically at how useful they are for patients with genetic frontotemporal dementia.
Genetic FTD, big topic these days, especially for us neurologists with all these potential treatments coming down the pipeline. Got to get good at picking up on those subtle cognitive changes super early.
Absolutely. Early detection is key, even before we see those really obvious symptoms.
I mean, that's the whole point of this deep dive, right? Trying to figure out which of these tests, the MoCA or MMSE, is better at picking up on those early signs. And not just in people who already have symptoms, but those who are pre-symptomatic or prodromal.
Exactly. We need to know if one of these tests is more sensitive, more accurate, especially in those early stages.
So how'd they go about doing this study? Like, who were the participants and what was the study design?
Well, they pulled data from two big cohort studies,
Oh, cool. Where were those done?
one in the Netherlands and the other in the UK. Pretty big data set collected between 2021 and 2024. They looked at both cross-sectional and longitudinal data.
So snapshots in time and also how things changed over time.
Exactly. There were 243 participants in total.
A decent sample size.
Yeah, and they had 157 folks who were carriers of those pathogenic variants. You know, the genes we know can cause FTD,
Like what?
like MAPT, GRN, C9orf72.
Ah, those usual suspects.
Yeah, those. Also, TARDBP and TBK1.
Got it. And I'm assuming the rest of the participants were the controls?
Right. 86 people, all related to the carriers, but they didn't have any of those gene mutations.
Good to have that comparison group.
Yeah.
So how did they split up those 157 carriers? I mean, you mentioned pre-symptomatic, prodromal, and symptomatic.
Yeah, so they used the CDR plus NACC FTLD score.
Oh, right. That's that specific scale for FTD.
Yeah, so folks with a score of 0, meaning no signs of dementia clinically, were considered pre-symptomatic. There were 119 of them.
Almost two-thirds.
Then there were 18 who were prodromal.
So they were showing some signs, but not enough for a full diagnosis.
Right. These folks had that progressive decline and had a score of 1.5 on that scale, but they also had to have cognitive decline, like at least 1.5 standard deviations below normal in one or more cognitive areas.
Makes sense. So more than just that score, they needed evidence of actual decline.
Exactly. And then, finally, we had 20 participants who were symptomatic.
So they had a clear diagnosis of behavioral variant FTD.
Yep. They met the criteria for a definite diagnosis.
Makes sense. All right, before we move on to the test results, tell me a little about the participants overall, like age, education, that kind of stuff.
Okay, so the average age for all participants was 49.9 years.
Pretty young.
Yeah, and they had a mean of 14.5 years of education, plus 56% of them were female.
Interesting. Anything else worth noting about the participant characteristics?
Yeah, the symptomatic and prodromal groups were a bit older than the pre-symptomatic and control groups.
Makes sense. The disease tends to show up a bit later in life.
Right, and the symptomatic participants had a bit less education compared to the pre-symptomatic and control groups.
Interesting. All right, let's get to those test results. What did they find about those total scores on the MoCA and MMSE?
Okay, so both the MoCA and MMSE total scores were statistically different across the four groups. Controls, pre-symptomatic, prodromal, and symptomatic.
So scores varied depending on disease stage. Not a huge surprise there.
Yeah, but the specifics are interesting. For MoCA, they had an F statistic of 16.565, and the p-value was less than 0.001. For MMSE, it was an F statistic of 13.529, with a p-value also less than 0.001.
So both were definitely statistically significant.
Yeah. And as you might expect, the control group generally scored the highest on both tests. Then the pre-symptomatic, then prodromal, and finally the symptomatic folks had the lowest scores.
Makes sense. But was there anything interesting when they compared those pre-symptomatic folks to the controls?
Yeah, this is where it gets interesting. For the pre-symptomatic carriers, their median MoCA score was 28, And the 95% confidence interval was 27 to 29.
Okay.
And that was statistically different from the controls, whose median score was 28.5.
Oh, so even that slight difference was significant.
Yeah, with a 95% confidence interval of 28 to 29.
Interesting. But what about the MMSE?
Well, the MMSE didn't show a significant difference between those two groups. The
What?
controls had a median score of 30 with a confidence interval of 30 to 30.
No variation there.
And the pre-symptomatic group's median score wasn't statistically different.
Huh. So it seems like the MoCA might be picking up on something that the MMSE misses in those very early stages.
Yeah, potentially. It might be more sensitive to those subtle cognitive changes that happen before any clear symptoms show up.
So for us neurologists trying to identify those at-risk folks early, the MoCA might be the way to go.
Could be, but we need to look at more than just the total scores.
Right. What about the overall accuracy of each test in telling the different disease stages apart? Like, can they reliably differentiate between pre-symptomatic, prodromal, and symptomatic?
Well, they looked at that too. Turns out the MoCA was better at distinguishing between the groups. It had an AUC of 0.87, with a 95% confidence interval of 0.81 to 0.94.
It's pretty good.
Yeah, an AUC above 0.8 generally means it has good discriminatory power. Now, the MMSE, its AUC was 0.80.
But still decent?
Yeah, with a confidence interval of 0.72 to 0.89. But the MoCA's higher AUC suggests that it's a bit better at telling these groups apart.
Interesting. Did they dig deeper into the scores, looking at those individual subscores on each test?
Oh yeah, they did a whole breakdown of the subscores. And for the MoCA, a lot of interesting differences popped up between the groups. For example, the visuospatial executive subscore. That was lower in the symptomatic carriers compared to both the pre-symptomatic carriers and the controls.
Okay.
And the prodromal carriers also had lower scores than the controls in that domain.
So problems with visual, spatial, and executive function seem to show up early.
Yeah, and they saw similar patterns in the attention and language subscores of the MoCA. The symptomatic and prodromal folks scored lower than both the pre-symptomatic carriers and controls.
Got it. So those domains also seem to be affected early on.
Right. Then you've got the naming and abstraction subscores. Those were specifically lower in the symptomatic carriers compared to all the other groups.
Really? So those abilities seem to decline later in the disease course.
That's what it looks like. Now, recall was lower in symptomatic carriers compared to pre-symptomatic and controls.
Memory problems not surprising.
No. But they also saw a trend toward lower recall scores in the pre-symptomatic folks compared to controls, although that wasn't statistically significant after they did all those multiple testing corrections.
Okay, so maybe some subtle memory issues even in the pre-symptomatic stage, but not a clear finding.
Right. And finally, orientation. That was lower in symptomatic carriers compared to pre-symptomatic carriers.
Makes sense. As the disease progresses, orientation can become a problem. What about the MMSE subscores? Did they show anything useful?
Yep, they did. On the MMSE, the orientation subscore, that was lower in the symptomatic group compared to all the other three groups.
Again, orientation problems seem to be more prominent later on.
Yeah. Then there's the attention subscore. That was lower in prodromal carriers compared to pre-symptomatic and controls.
Okay, so attention issues might be a signal of that prodromal stage.
Could be. And for recall, that was lower in symptomatic carriers compared to pre-symptomatic and controls. They also saw a trend for prodromal carriers to score lower than controls, but again, that wasn't significant after the corrections.
So similar pattern as the MoCA, with recall problems potentially showing up early.
Exactly. Now, language was lower in symptomatic carriers compared to all the other groups, and the prodromal carriers also had lower language scores than the controls.
Interesting. Language seems to be affected across those later stages.
Right. And then there's the construction subscore. That was lower in the symptomatic carriers compared to pre-symptomatic and controls.
Okay, so constructional abilities decline later as well.
Yeah.
And anything noteworthy about the registration subscore?
Nope. No significant differences between the groups there.
So overall, it seems like the MoCA subscores are a bit more useful in teasing apart those different disease stages. Did the study look at whether the specific gene mutation mattered? Did people with certain mutations perform differently on the tests?
They did, and this is really cool. Only the MoCA was able to differentiate between the different genetic subtypes.
Wow, that's pretty remarkable.
Yeah, so after they took into account disease severity, the total MoCA score was lower in the people with the C9orf72 mutation compared to those with the GRN mutation.
Interesting. Why might that be?
Well, we know different mutations can lead to slightly different clinical presentations. This might reflect those differences.
Makes sense. And what about the subscores?
They found something there too. The MoCA recall subscore showed that the carriers of the MAPT and C9orf72 mutations, they performed worse than the GRN carriers.
Fascinating. So certain mutations might be associated with more pronounced memory problems. This is really useful information for us neurologists.
Right. Knowing these subtle differences can help us tailor our approach to each patient.
Absolutely. So we've seen the MoCA seems to be better at distinguishing between disease stages and even genetic subtypes. But how good are these tests at actually predicting or classifying people into those different categories? How accurate are they?
Well, they use this statistical method called AIC to figure that out. And the AIC suggested that the MoCA was a better overall model for predicting which group someone belonged to.
So in terms of overall accuracy, the MoCA wins again.
It seems that way. Now, when they looked at the ability to distinguish between specific groups, both tests struggled a bit with telling the controls apart from the pre-symptomatic carriers.
Yeah, that's that really early stage where things are subtle.
Right. But the MoCA was better at distinguishing the controls from the prodromal folks and also the pre-symptomatic from the prodromal. It did better than the MMSE on those comparisons.
Okay, so again, the MoCA seems to have a slight edge in those early stages.
Yeah, but both tests did a pretty good job of telling the pre-symptomatic carriers apart from those with prodromal or symptomatic disease. Though even there, the MoCA had a slight advantage.
Interesting. Did they come up with any specific cutoff scores? Like if someone scores below this number on the MoCA, it suggests they might be prodromal.
They did. Based on their data, they suggested a cutoff score of below 28 on the MoCA to distinguish pre-symptomatic carriers from controls.
Yeah.
And for the MMSE, they suggested a cutoff of below 29 for the same purpose.
So similar cutoffs.
But for differentiating controls and pre-symptomatic carriers from prodromal carriers, the MoCA cutoff was below 27.
Okay, a bit lower.
And the MMSE stayed at below 29.
Got it. But are these cutoffs good enough to use in the clinic?
Well, the researchers cautioned that the specificity, particularly for the MoCA at that pre-symptomatic stage, might be too low for making clinical decisions on its own.
So can't rely on it completely.
Right. And they found that education level played a role, too. People with 12 or fewer years of education tended to have lower mean scores and might need different cutoffs.
So another factor to consider. Education can definitely impact cognitive test performance. Now, this study also looked at how things changed over time, right?
Yeah.
What did they find in that longitudinal analysis?
Yeah, over about a year, both the MoCA and the MMSE showed a significant decline in scores in the overall group.
So regardless of the test, we're seeing cognitive decline over time.
Exactly. And the decline was particularly noticeable in the prodromal and symptomatic carriers on the MoCA.
Okay, so it seems to be more sensitive to change in those later stages.
Yeah, possibly. And on the MMSE, the decline was most evident in the symptomatic carriers.
So MMSE might be better at tracking changes once symptoms are more pronounced. All right, one last thing. Did the study look at the relationship between those cognitive test scores and behavioral symptoms?
They did. And the MoCA showed a stronger correlation with scores on a behavioral assessment scale. They used the FRS.
The frontal behavioral inventory. Okay,
Yeah.
so the MoCA seems to be more closely linked to behavioral changes,
Yeah, more so than the MMSE.
which makes sense given that FTD often presents with those behavioral symptoms.
Right. And here's the really interesting part. When they controlled for the behavioral symptoms in their analysis, the differences in MoCA scores between the groups became smaller.
So it seems like there's some overlap between what the MoCA is measuring and those behavioral aspects of the disease.
Exactly. The cognitive impairment picked up by the MoCA might be partly reflecting those behavioral changes as well.
Fascinating stuff. So for us neurologists in the trenches, what's the takeaway message from all of this? Which tests should we be using?
Well, based on this 2025 neurology paper, the MoCA seems like the more sensitive option for screening for cognitive issues in genetic FTD, especially in those early stages, the pre-symptomatic and prodromal phases.
So for those at-risk individuals, the MoCA might be the better choice.
It seems that way. It was better at picking up on those early cognitive changes, even before symptoms emerged. And it was also better at differentiating between those early stages and healthy controls, compared to the MMSE.
And you mentioned it was even able to distinguish between different genetic subtypes.
Right, which the MMSE couldn't do. Now, while both tests show a decline in scores over time, the MoCA might be more sensitive to those changes earlier on. But we always need to be mindful of education level when we're interpreting scores because that can have a big impact.
Absolutely. And while they did offer some cutoff scores, we can't rely on those alone to make a diagnosis.
Right, those cutoffs might not be specific enough, especially in those early stages. And we also have to remember that the MoCA seems to be pretty closely linked to behavioral symptoms. So it might be picking up on both cognitive and behavioral aspects of the disease.
That's really interesting. Thanks for breaking down this research for us. Definitely give me some things to think about.
No problem. Always happy to dive into these studies.
And for our listeners out there, just a reminder that this was just a summary. Be sure to check out the full paper in neurology for all the details.
Definitely.
And one final thought to leave you with. Now that we've seen how the MoCA might be a more sensitive tool for early detection in genetic FTD, how might you integrate that into your own clinical practice? Could it change the way you approach screening and monitoring these at-risk individuals? Something to ponder. And that's a wrap for this week's Neurology Deep Dive. Thanks for joining us.
See you next time.